Hello, everyone. Thank you for joining us for today's episode of Let's Get Vaccinated on HoodMed Chats, HIV and the Black Community. Oh, sorry. Sorry about that. I'm Dr. Nisi Hudson, Chair and Science Director of Hood Medicine. And today we're going to be talking with guests about HIV and the Black community. And I have with me my co-host, Jonathan White.
Sorry about that. I was having some technical difficulties, as always. I'm Jonathan White, co-founder and director of policy engagement for Hood Medicine.
Hood Medicine Initiative is a nonprofit collective of scientists, physicians, hackers, and assorted geeks focused on health equity and reducing the spread of dis and misinformation.
Our HoodMed Chats podcast connect health experts and activists to bring real talk and mad science to our communities.
So today we're chatting about the ongoing HIV crisis in the Black community, the lessons from the HIV epidemic that we failed to learn before COVID, and the similar health equity issues at play for both. And I am thrilled to finally welcome to the podcast one of my best friends, Dr. Aaron Neely. He's a professor at Grand Canyon University in Phoenix, Arizona, and president of Stride Community Services Incorporated. He completed his MS in human and animal physiology and developmental biology from the University of North Texas at Denton, and has an MS and PhD in pharmacology and toxicology from U of L in Louisville, Kentucky, where he developed novel chemotherapeutics in the treatment of prostate cancer. He completed his postdoctoral fellowship at Beckman Research Institute in Los Angeles, California, and in the Department of Cancer Biology, he investigated prostate tumorigenesis, where he engineered mouse models to elucidate the prospective roles of key players in the disease's progression and potential severity. So happy to have you with us today.
Angelia Moore is a community advocate and an experienced business leader working in nonprofit management and development. She has an MBA from Western Governors University and previously worked as a coordinator of HIV case management and as the vice president of programming for the Edna Martin Christian Center in Indianapolis. Thank you for coming.
Thank you.
And last but not least, one of my favorite people in the world, retired psychologist Dr. Quinn Shipley, who uses pronouns he, him, and serves as an ad hoc community advocate for Hood Medicine. He's from Memphis, Tennessee, and earned his BA at Rice University and his MD and PhD from the University of Louisville. Go Cards. He also holds a Master's of Divinity and a Master's in Clinical Psychology. His life experiences included the practice of and teaching of psychology, brief training in psychiatry, and he earned a doctorate in the humanities, in which he researched the effects of alcoholism on literary creativity. He's currently completely retired and holds himself as a volunteer advocate for social justice rather than as a practicing licensed professional. Welcome back, Quinn.
Yes.
Thank you.
Angelia, we'd like to start with you and have you give us some background on your experience as an advocate, and then give us an idea of where we are right now with the ongoing HIV epidemic in the U.S., where Black communities still have the highest burden of infections and new diagnoses of any ethnic group in the country.
Sure. So around 2007, I was working in healthcare and ended up doing preparation for a HRSA grant, and got into the work, realized that my practitioners were phenomenal, but they didn't know how to handle patients of color. And so I tell people all the time, if I ever get the virus, that is where I will go. I know they will take care of me, but it wasn't me that I was worried about. It was the 24-year-old who made it 10 minutes late and began to cuss out the staff and was getting ready to be dismissed. And I knew that there was a space for me to make sure that having the best care, but not having access to the best care are two different things. And so, yes, the organization provided the best care, but our people were not able to receive it because of behaviors, because of stigma, just on and on and on. And so got into HIV, got into advocacy around HIV, and working with providers and making sure they understood how to serve people of color. Um, and did that for 7 years. Changed roles, kind of left the data alone a little bit, and really worked focused on making sure around our TGA, which is our transitional grant area, that we were serving people of color, because our diagnosed appropriately because our diagnoses were going up. Young men who were MSMs or men who have sex with men, 18 to 25, were walking in the door positive, sick, and ill. And then we had women who, as young as 18, who were still in high school, who were testing positive. And so, what does that care look like? How do you treat someone you don't understand? And is there anything that we needed to do on the clinical side to make sure we were addressing the inability and the no-show rate for our clients? And so that was the beginning of my HIV career. And then the numbers just haven't really gotten better. So I remain in that space. I have the conversations. I'm a proud mom of four. I've had it with football teams, cheerleading teams. If there's two or three women sitting there, we're probably going to end up on that conversation. Breaking the barrier and the stigma means having the conversations openly and honestly in as many places as we can.
Erin, can you tell us a little bit about your advocacy work and what, if any, nuances you can explain for our audience and how the epidemic like hits a little different among the LGBTQ community, particularly the disproportionate impact on Black and Brown queer folks?
Can you hear me?
I can hear you.
All right. So I guess my advocacy started in 2012 in North Texas, working with the North Texas Health Services, and Christian Community Action was another, I guess, nonprofit organization out there that worked with underserved and uninsured individuals. Um, and essentially, what we saw was that there was just, I guess, gradual progression towards, um, you know, uh, I guess, these individuals in these communities, blacks and browns specifically, as Jonathan mentioned earlier, being more burdened with this disease. We also saw what Angie talked about with respect to, just how these patients were interacted with, I guess in conventional settings. And so um, we saw that, women, like black women, were um, increasingly infected, and that their mode of infection was heterosexual um, contact. We saw that while other ethnic groups saw declines in infection rates or prevalence and incidence rather, um, we saw infection rates remain stable across black men and women, across both sexes. And so I don't know. We basically found that education and outreach was probably the most most critical, I guess, point in any flow or approach that we would have employed. Just that that there's a lot of ignorance that still that's found just with just how much people understand about the disease, and equally the stigma is still very much alive. And that was in 2012 to now. It hasn't changed. As a matter of fact, it may have gotten worse. If you look at the LGBTQ IA plus community, um, in a community that has shouldered the epidemic and everything that came along with it, the stigma is still very much alive within that community.
Mm.
Um, and when you look at the micro compartments of that community, I mean, it gets worse. That may be a little counterintuitive, but you see certain labels that are now being ascribed or associated with someone being HIV positive. Dirty, versus clean. And I don't know. I mean, I think it's a multi-layered, I guess, issue, but uh, I think that there's hope. We see, all the progress that we've made with, um, medication to, even, diagnosis and prevention. But I don't think that, access to these things is equitable, and I think that's probably, that along with, education and outreach would probably be, best places to start.
Interesting. Quinn, the Human Rights Council emphasizes the equally important epidemic of HIV related stigma. Can you talk to us about how that stigma has evolved since the early days of the virus?
Okay. One of the advantages of being an old guy is that I was there when it started, and uh, I self-identify as, of course, my pronouns. We've already mentioned that, the he and him, but I am a gay man, and the uh, the uh, reality was that when the disease first started appearing, before it was labeled, either HIV or AIDS, the first label that came out was
Kids.
GRIDS,
Yeah.
GRID, gay-related immunodeficiency disease or syndrome, and so it was highly specifically associated with the stigma of being gay at the time, and also having this unusual disease that no one really understood. I mean, they really didn't, because they had not experienced anything like this. At the same time, and this shouldn't be ignored, the other community among which this was emerging was among the Haitians. The Haitians, both in their nation, and also the Haitians who were in the diaspora abroad, and so you immediately started seeing the notion of the disease with marginalized communities, and therefore there became the association that, uh, first of all, it's only going to happen if you're marginalized,
Mhm.
which of course was not true.
Mhm.
Uh, but secondly, that if you did get the disease, then you would become marginalized. It had the reverse effect with the variable on that. So uh, that's just a little bit of the history. It took a while for them to even figure out that it was a virus called HIV as opposed to HTLV3, which was in the leukemia range of viruses. Uh, but the stigma was real, um, and persisted. Um, it is interesting. I don't know if it's appropriate time to talk about it now, but the response uh, from activists within the community was sort of a double pincher response. Some was using the arts, and high-profile arts, such as Hoffman's play As Is in 1985, The Normal Heart by Larry Kramer in 1985, which got broadcast on PBS. Later on, Angels in America in 1991. Uh, so we started seeing, but you have to recognize that these are productions and creations from, um, quite frankly, positions of privilege. Now,
Mm.
they were using their positions of privilege for a good cause, and that's good. But we have to recognize the fact that not everyone gets to publish plays and have them produced on Broadway, and or have PBS broadcasts of things. The other aspect of it too was the advocacy early on. They recognized that early on that playing nice didn't really get you much of anywhere.
Mm.
And so Larry Kramer, who had no background in science or medicine, I mean, he was a playwright and a producer, and he was quite good. He 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 basically started becoming the voice, and started the gay men's health crisis. He started ACT UP. They started using techniques, methods that were uh, intended to get people irritated,
Mm.
to get attention, putting condoms in the offering plates in churches. They targeted. uh, their attention towards very important individuals, Dr. Fauci included. In fact, Dr. Fauci will tell you that these days that it wasn't necessarily a pleasant experience, but the ACT UP community and Larry Kramer in particular, they changed the way that he viewed what was happening in the world, in his world of virology. They changed the way because they gave it a human face. Now, unfortunately, it tended to eddy off into something that was specifically gay and associated an awful lot with gay white men and with some degree of privilege. And, and that left other populations behind. And it definitely left, there's no doubt about it. There was never the depth and reach into the Black and brown community in the way that it needed to have been done at that time and the way that needs to be done now. So I hope that's enough of an overview at the moment, but thank you.
Yeah. And while the nature of these two viruses, is vastly different, there have been a lot of similarities, I think, between the two epidemics of HIV and COVID, in early stigma, in the misinformation, certainly in failed public health response, especially among Black and brown communities. So I wanted to just kind of open up the discussion to all of you and get your take on how the ways you see us revisiting those same failed policies during the COVID pandemic. Aaron, I'll start with you. What are you seeing that is reminiscent of what we didn't do right before?
Well, first I want to shout out Larry Kramer, R.I.P. Definitely a legend in this kind of work, specifically when it comes to underrepresented and individuals. As far as I guess similarities, pertaining to both viruses, and embarrassingly, and I think we should all just be embarrassed by this, just because we've dealt with similar instances before, and we caught with our pants down again in certain regards. I would think that the fallout surrounding racially related health disparities in the past would have, I don't know, maybe just inclined government officials to make sure that wasn't the case moving forward. We know that right now, the misinformation around or disinformation around the pandemic was, I think, a rate limiter of sorts. It definitely changed everything that would follow. If that makes sense. So we started out with hearing, so we had this proliferative culture of conspiracy theory, right? And that was before COVID, right? Um, with HIV, there wasn't a lot known about that virus. Same with this one, and the approach, I think, I think that they were similar. We look at Reagan during that time, and we look at him this time, Donald Trump during this pandemic at its its genesis, and we see just an inability and an unwillingness to say we don't know, and to say we're all at risk, and maybe just trust the general populace with the truth. I kind of feel like even the stagnation of science we saw in the 80s, almost into the 90s. We saw again here. We saw that any progress was sort of immediately industrialized, and monetized. We saw discussions about who should get treatment, We saw this bartering of life, or leveraging economy with human life. And I don't know, it's sort of scary, because at this point, I don't know if it's drawing, or comparisons or contrasting. I think this is just the way that things are done. I think that whenever the next pandemic comes, we're going to be contrasting COVID with that one. And what we're going to see is this list where there aren't that many contrasts, just similarity is just, a trend, the motif sort of forming. We even that we know that.
Uh-oh. I think Aaron froze.
Yeah.
Uh-oh. Anji, I'm going to move to you really
Okay.
quick while he reconnects. What are your thoughts on the similarities here?
So I think the biggest similarity that I've seen is the lack of trust um, for the medical field. So when we first got news of COVID coming out, it wasn't real. We didn't think it was happening, um, but the death rate was alarming. And as we progressed through it, the rush to vaccinations and treatment left the Black and Brown community very much fearful, especially younger Americans, younger African Americans. My house is split, so half of us are vaccinated, half of us are not, and it's simply because they don't trust the system. They um, they don't believe that science can move that fast, no matter what we share or say. And when you think about HIV, we can prevent HIV right now. We have PrEP. But we are not even ready to say we are ready to treat HIV before we begin to have PrEP. I'm a proud mom of a queer son, and getting him to talk to me about PrEP wasn't comfortable, but the same energy and effort we put around talking to our daughters about birth control, we need to talk to all of our children or young adults about PrEP. This is something that can help make their lives easier. We know that they are safer. I would much rather prevent HIV than have him in a system where he would have to get support the entire time to pay for the cost of treatment. Prevention is much cheaper, um, and I mean we have to be able to have those open dialogues around what is really going on and having those conversations, because there is a lack of trust. Um, you know, and getting people to be okay with having the conversation. If we saw someone with diabetes eating cake, we'd be like, "Are you okay? Are you sure that's something you should be doing?" So those same conversations help break the stigma.
That's so true. Sorry, Aaron, do you want to finish your comments? You cut out technology.
Yeah, no, I was just saying that I think we're sort of reaching this point where, and I'm not saying that we have to accept the way that things are, but I think we definitely need to acknowledge that the trends that we're seeing, they may be off-putting to those of us who are impacted by them, but by those, I guess, in the mainstream, this is a norm. The
Mhm.
norm is that if something hits the general populace, those that, I guess, belong to, the largest sects of the community, are a priority. Um, there will always be disinformation. That's just our nature. There will always be an ease of subscription to any, fallacy, or anything that's whimsically idiotic. I mean, let's just call it what it is. That people are more inclined to, to cherry pick, science, or anything that we may deem, standardized, established, or something that we, that there's a system, and this is something that we've trusted for so long. They will trust that system until it doesn't serve their purpose. So we're cafeteria. It's almost like cafeteria picking. on the other side, it's like this understanding of general populace, mindset and thinking and behaviors, eventual behaviors, um, is actually sort of, well, I guess ultimately it's weaponized, right? It's politicized. It's used and it's sort of molested in a way that to where they essentially we see what we're seeing right now, right? You see the fights on airplanes because I don't want to wear a mask. You can't prove that masks work. Or I don't want you getting me sick. Okay, well now I'm gonna put my hands on you because you believe in this crazy. But
Very crazy.
what's now crazy is, I mean, you not even a year ago, a few minutes ago, you picked up a device that crazy actually developed. You know what I mean? You depend on crazy every other day. You go to the doctor when you need it, but now it's crazy, and I don't know. I think right now we just need to accept it for what it is before we can even deal with it. I think this is something that has persisted in other pandemics or epidemics, and I mean we're just seeing it now. And I don't know, maybe we're more off put by it because technology and everybody being able to bear witness to it in real time. But I think this is just the way it's always been, and this is how it's going to be. I think what needs to change is our response to it.
Yeah. Quinn, what do you think?
Well, it's interesting that to see that there was an initial similar response of unreasonable fear in both virus situations. With HIV, it was one of those situations where people weren't even certain whether they could be in the same room with someone who had HIV. They wouldn't admit patients in their dying days to nursing homes. There was like only one nursing home here in Louisville that would uh, you know that would take HIV patients. And in the same way, I mean, with COVID, people were, I mean, they were more interesting. They were more interested in wiping down counters with Clorox early on than they really were interested in paying attention to the respiratory nature of the illness. So you had these really, really unusual things that were happening. And then later on, you had the same sort of reverse of the situation of this casual approach of, oh, well, it's really not going to hurt me because I'm different somehow, or, some religion's got my back, or, we're going to, we're going to be careful in this way. And it's sort of like, just not paying attention to just the real facts of the science about the matter. So that's one of the things that's interesting. For me, it's interesting to know that, I mean, and this is where there's a difference with, I mean, one of the side effects of us masking well the few times that we actually did it as a nation is we reduced the influenza. Uh, a year and a half ago, we just about didn't have any influenza cases. I mean, it was just
Mhm.
amazing. Um, no,
But
that's
why
not
is that, Quinn?
because we
Why
were
is
wearing
that?
masks. We were
Thank
wearing masks.
you.
And so what's interesting about it, not to get us diverted, but the whole point about sexual health is that not only is there HIV, there's still HCV. And this is not something to be just it is not easy to control. It's not nearly as easy to control, quite frankly, as HIV is these days. And HCV has its problems. We have a massive emergence of syphilis and Neisseria gonorrhea cases and chlamydia, and particularly when you start talking about moving into the heterosexual community and these types of things, chlamydia has a lot of people just kind of pass it off as like, well, so what, 1 gram of Zithromax and you're okay. The reality is, if you don't know that you have it, and many women don't, it can lead to PID. It can be reproductive issues or immense. So the whole point of it is that when you have good medicines, and I'm gonna classify good vaccinations, good vaccines, immunizations as good medicine. When you have good medicine, you have good prep. When you have amitriptyline and tenofovir and things of this nature going on, those are good. And I'm not saying don't use them. I think you should, but we can't also throw away the barrier protections. They have to both be in part of public health. Barrier protections and good medicine and good social practices as well. They all have to be together, and that's where the diseases are so similar, that we have these three different things. We have good medicines, we have good barrier protections, we have good social practices, and then when we put all of those three things together, plus destigmatizing. Now, I did have the advantage of uh, I was able to be in Tanzania with a group that worked with a community that was severely affected by HIV, and there the primary means of transmission was heterosexual.
Mm.
No doubt about it.
Mm-hmm.
And there was like this community had a 40% prevalence rate. We lost an entire generation. We have now kids who are orphaned and at best being raised by grandparents if they're being. Uh, but there was a great response that was set up there, and it turned it around. And one of the things is, for instance, you had young people wearing T-shirts that said in Swahili, "I've been tested. Have you?" And they were. It became a point of pride that they were willing to emblazon on their chest. I've been tested. Have you? And there were uh, normal lay people who were trained to go into homes and to be able to talk to people about what they needed to do and how to get to clinics and how to get onto medications and things of this nature. So it required grassroots work. It required taking on the stigma directly and doing what you could do with it. Um, and uh, and it required talking about things that people wouldn't have talked about before, having to talk freely about condoms and use of condoms, having to talk about medications and HIV. So, but those are some of the things that I've noticed that are similar, and there are some differences, of course, but I think there's some similarities which were very important.
I'm glad you brought that up. We're gonna do a really quick science break. Um, just to underscore everything that you said about barrier protections and the fact that viruses are just so crafty and scrappy and versatile. Because as we know, HIV can also mutate, and it has. There's new variants of that as well. Um, and so we just want to do a quick refresher on everything because it is a slightly different type of virus than COVID, and we want to make sure people know what we're talking about. um, HIV is a retrovirus. We've gone over how coronavirus works many, many times, how it spreads, et cetera. And as we're saying, that's a little bit different, right? And so COVID, as we know, is spread in breath droplets from people who refuse to wear masks. But for HIV, hopefully we all also know by now that it's spread by sexual contact and other bodily fluids like breast milk and blood. In essence, just like with COVID, the virus enters your cells and it kind of steals your copy machine to make its own copies, right? And so the copy errors that sort of rack up as it is going crazy with your machinery making all its copies, they accumulate. And that's how these subvariants come into being, right? So then your cells start pumping out viral particles. They travel to other cells first, then to other tissues and organs, put that work in, you get sick, and then eventually the viral load increases and they find their way to an exit, which is when you then sneeze on everyone in the Applebee's and it goes to find new hosts, right? Now, normally, the way our cells work is that they kind of read our DNA code like a book, right? They code it into RNA, which is a single strand. And then that RNA code is used to make the proteins that our cells need for our body's like everyday functions. But HIV is a little different because it is a special type of RNA virus called a retrovirus. So, just like with COVID, its genes are encoded in RNA, and it also steals your copy machine to make copies of itself. However, retroviruses take an extra step in the process, and this is why they're called retro, because they reverse the direction of that normal gene copying process. So it codes the RNA to DNA, and then that viral DNA goes inside your actual genome. And so that's how it starts to trick your cells into copying its own genes instead of yours. But then it also allows for that DNA to RNA to protein process to happen, making more viral proteins that infects other cells and other people ultimately. So, and then many of the HIV therapies that we have actually work to prevent that process where the virus becomes a part of your genome and thereby kind of slows down, like shutting down that copy machine hijacking before it starts, right? So, just like, with COVID, like Quinn was trying to underscore, you need barriers to infection. There are vaccines, there's multi layers of protection that one needs to protect themselves from a virus. But physical barriers are the most important because they have to physically get inside your body in the first place. And that's really, up to you whether or not that happens, right?
Yeah.
Yeah, I think one of the major commonalities between the spread of HIV, or preventing the spread of HIV and preventing the spread of COVID, is, for HIV, if you're abstinent, you can't spread it. If you're, if you, in this COVID environment, if you stay home, and we, kept the shelter at home policies in place, we'd be a lot better off. But it's just the commonalities between the two and how bad we've, addressed them. It's just
Mm-hmm.
kind of sickening to think about. Aaron, what have been some of the challenges that you've seen in HIV patient care due to the COVID pandemic?
Well, I mean, I guess so. During the pandemic, we saw limitations in access to care. And I guess that's across every disease state, but specifically with HIV, it was increasingly difficult for patients to get in to see physicians. You know, it, be it transportation programs that were in place. I guess during normal times. Were just sort of either affected by a slash in funding or just an over just exhaustion of resources. Everybody's focus sort of pivoted, whether we liked it or not, right?
Mhm.
COVID was the new order of the day, new flavor of the week, and what that means is everything else falls by the wayside, including the viruses that that have sort of ravaged us. You know what I mean? Like Dr. Chipley said, we lost a whole generation to HIV. But we we saw. I even heard reports about. Um, I guess even the quality of care that individuals would receive. Going into to see, whenever they do get to see a physician or whoever staffed at that facility, just the way they are handled. And I don't know if it came out of fear. I don't know if it came out of or just pure ignorance. Maybe maybe a relapse in the loss of you know humanity and caring. Just offering basic human care. Something definitely changed during this pandemic, and you heard the reports. You heard just within the community. You heard people you know in real time saying, electing that, what, I'll just use whatever meds I have left, and hopefully by the time I'm out, this is all over. Um, and I actually, funny enough, I remember one of the conspiracies, I guess, or what one of the modes of thinking out there was that HIV, antiretroviral therapy would um, would I guess treat COVID, and so there was this weird I guess mindset surrounding
Mhm.
that and it was sort of odd just because it was more fascinating than anything else just because you have this community that was sort of labeled well had this the progression of this disease attributed to them. Now I don't know if I want to say feeling vindicated in some way or somewhat. It was just a changed a changed I guess mindset in HIV um, uh, individuals for patients, HIV positive individuals, specifically in the gay community. Um, and to be honest, there's always the underbelly, right? And I think the dark part of the underbelly would have been just this recklessness that came with all of that. Um, I know that drug use definitely increased, and be it because of I guess the banality of the day, and just having nothing else to do, or just being defiant because the man said that this is we have to stay in place, so I'm going to do the opposite. There, I mean, just rampant, you know, um, reckless behavior. Um, you know, um, Concerted with drug use that we saw, uptick that skyrocketed. And I think right now, one of the you know results of that is just increased HIV incidence. Um, and at a time where we have an arsenal filled with tools, um, it's sort of disconcerting to be honest.
Mm-hmm.
And especially as people of color, most you know most especially as people of color, we have enough to deal with. Every determinant of a health outcome that was listed, whereas to you it may be a determinant, but to us these are obstacles. You know
Yeah.
what I mean? And these are things that we live with on the daily. And so I think I don't know. I think something definitely needs to be changed within the most affected communities as well. The mindset has to change, the approach has to change, and we need to start speaking up. We need to, but I think to speak up, we have to actually be concerned, and I do feel that on some level there is also a lack of concernment.
Angie, I'm going to turn to you next.
Real quick, I think one of the things that we missed in our chat today is understanding that often we talked about some of those fears are institutional fears, but oftentimes people of color don't go for preventative care.
Mhm.
We go for symptoms. And so
Mm-hmm.
if I give you the symptoms of HIV and I give you the symptoms of COVID, they're very similar. If I give you the symptoms of a common cold, they're very similar. And so we're getting to the hospital or into medical care at a much at a rate that we're high, or we're more the infection has taken over and we're sicker than if we were preventing it. And then secondarily, um, while we were on those orders to stay at home, and we, of course, there was more sexual contact, but there was also more drug usage. We are still in a epidemic around our needle usage, and the federal government and state governments have not done safe needle exchanges everywhere. And a lot of the places where you would go to get safe needles or condoms during the stay at home orders were closed. And so we are seeing the response to those things. People, it's about a year or two out, people's viral loads are extremely high because they could have gotten sick during the pandemic and the stay at home orders. And there were no, we talked about the barriers. We gave out masks, but we forgot that condoms weren't being passed out, safe needles weren't being exchanged. And so you use what you use while you're at home. And if we're using together and we don't have anything that will protect us, at this, that wasn't the priority. And if I didn't feel sick, there was nothing that said to me, go to a doctor. People were still in denial around even having COVID. So, and the symptoms were so similar. We find many people don't find out until they've been to the hospital 2 or 3 times for what they believe to be pneumonia, and they'll test for HIV. If you don't look like you're using drugs or you're not telling them that you're a sex worker, they might not even test generally. When I had my last child, they said I was married, I had insurance, and they didn't think it was a necessity for them to test me for HIV. Those type of things, it's education on both sides. It's education to the community. It's also education to the doctors around making preconceived notions or beliefs that testing is not necessary.
Yeah. And I guess in terms of, to pivot a little bit back to the disparity conversation, Angie, can you tell us a little bit about these new, really alarming infection rates among Black women? Just recently, we've seen that Black women now account for nearly 60% of the new HIV infections in women in the U.S. Why are we failing this patient population? It's not rhetorical. Please answer the question.
I think we've kind of hit on it. Our women are not going in until they're sick. Moms take care of themselves last. So cough or runny nose, those introductory symptoms, I wouldn't go to the doctor. And if you have little ones, or if you have smaller kiddos, or if you have a busy lifestyle, getting to the doctor and not the ER is kind of difficult. We saw during the pandemic that the stores that remained open were like our convenience stores, our gas stations, places where those who are already marginalized would be working. So that alarming rate, like kids were at home, but our convenience stores or Family Dollars, all those things stayed open to 7 or 8 o'clock. So the doctor's office, if it was open, has already closed. Knowing how to call in and ask questions about should I be tested for COVID and or HIV?
Right.
And the stigma is still so strong. Who wants to walk in and say, I think I need an HIV test, if the doctor or the nurse or anyone in the practice is going to look at you because they think that you've done something wrong? And so you wait. And so our women are, one, take care of themselves last. Two, we have a high criminal rate. And so when men are released from prison, if we're not actively testing and making sure that we know their status, the first thing they do when they release is enjoy what they've missed. And I'm not gonna challenge you and tell you that I want you to get tested first. So here we go. And so we're seeing more and more. We're doing much better with testing prenatally in the last 10 years. But the problem is, by the time she's pregnant, she's positive. And so we're catching it, and we're getting the babies born healthy, but mom is already positive. And in those who are actively living in the HIV world and understanding that undetectable means untransmittable, that's great. But we also have to understand that I need to know that you're undetectable, and not asking those hard questions. Are you positive? Are you undetectable? What was your last set of numbers? Means that I'm putting myself at risk. And women are just, they are wanting the attention and affection that they desire, and not asking the questions, the difficult questions. And we briefly mentioned Hep C. Hep C affected more people of color. And so the dollars in education and training weren't there for that. Ryan White was a young white male. And so those dollars went to white gay men who were living with the virus, because they had the voice, they had the politicians, they could get access to them. But Hep C is at the same alarming rates as HIV. We just didn't talk about it till recently because it's finally hitting someone that has a voice. So until it, it's just like breast cancer. We never saw pink ribbons until someone's mother, I think one of the politician's mother-in-law got breast cancer, and then we had pink ribbons everywhere. It doesn't hurt. It doesn't help people. It doesn't get publicized and pushed until it affects those who are in power. And this is the stigma is still there. So even if if I was president and my child had HIV, how likely am I to post that red ribbon and say, let's do something different?
Mm-hmm. So one quick follow-up, I guess, maybe for you, and then for Quinn to address from a different side. But what are we doing to kind of outreach to women in our community to have those hard conversations? Are we even, I know there's rampant homophobia still in the Black community. Are we even acknowledging or taking in the risk, like you said, if there are, risks from people who are returning from prison, or even from people like on the down low, because they're too afraid because of stigma and our inter-community bigotry to come out. How can we start these conversations amongst ourselves as Black women?
I think this platform is one. I think wherever and whenever we can have a conversation and just say the words,
Mm-hmm.
have you asked your partner about HIV? Are you using barriers to, if we're going to be active, are you using barriers? And that's in drugs and in sexual activity. And, we have, in the Black community, it took us years to have the conversations around birds and bees. But now we have to expand and actually talk about, the ants and the, whatever you want to call it, but expand that category so that we are bringing at least our children the truth. Calling body names by body parts by body names, and not being afraid to give them that total information. When my son came out to me, the fear of him was his family would abandon him. And we do have that in our community. But so that means that the rest of us have to wrap our arms around these kiddos and these young people so that they can be safe in their practices. We know that once you turn the sexual start on, it doesn't go off. So do we leave them ignorant because we don't want to talk about it, or do we give them the tools? I have a very strong faith. My church wasn't as open as I was when I got into HIV, and I would have condoms in my purse, and that was all that was in my purse, and I would leave it sitting on the pew. So if you wanted condoms, come and get them. If you wanted a conversation, you just let me know. But I wasn't going to let children just walk around me ignorant, and I had the knowledge. And so I think, how do we break that? We continue to talk about it. We did a very good job of talking about COVID across the nation, but that same energy needs to be put into HIV and Hep C.
And Quinn, I just wanted you to follow up really quickly, because I know you talk a lot about intergenerational trauma from the epigenetic side, right? And from the side of how that impacts the psychology of a populace. But I guess from how do we begin to break those stigmas from a psychology perspective? Like, and especially when we still have so much stigma, we still have so much prejudice, how do we begin to have those conversations and create safe spaces to do so?
I can say that the way that it happened within the gay community in the late 80s and the 90s, early 90s, was direct marketing to where the gays were gathering. And so you would end up going to bars, and you would hand out condoms. You would talk to people about what the process of transmission of the virus was. You would stock, fish bowls at the bars with condoms, so that and so it really got the conversation going at that point as far as that was happening. The same thing, quite frankly, is happening at some level when you get the funding and when you get the personnel actually at work with some of the with the needle exchange programs these days with the community of people who choose to use drugs. Um, so that does sometimes uh, uh, happen as well. Um, so, but you have to go where the people are gathering who are going to be the ones at risk, or the ones who are causing risk. And you have to be willing at times to ruffle some feathers. Now when you're dealing with bars, those the gay community bars actually were quite open to bringing uh, the community health workers in to
Hmm.
actually provide the issues. Um, but being able to simply uh, talk about sex in perhaps non-gendered terms, as we mentioned earlier, but just and not pointing at anybody out, not calling anybody out, not uh, not causing someone to fear that they are going to be uh, um, exposed to someone on the down low, for instance. Um, that's very important. Uh, and also, if you can get spokespeople who are willing to say, "I've been through this," I was living afraid of my own stigma. I understand how I got into this situation, and I'm glad that I'm getting treatment now to be healthier. But you don't have to go through this if and getting the people who've actually been there to actually talk about what their situation is. So that is going to be one of the most important ways of of getting at that community. Um, uh, I mean, I'm reluctant to make many statements about what to say about what to do with the black community and the brown community because I'm so ridiculously white. Uh, I mean,
Quinn, are you serious? Are
I
you
just
serious? Wait.
no. I guess
no,
I wanted you to speak more so from like
yeah,
how does one break stigmas in the sense of psychology? How do you attack someone's
you
fundamental
you
beliefs and prejudices, kind of thing?
you get the person who's been through it, who has actually
Absolutely.
who has dealt with it themselves and who has gained their voice and their competence to be able to speak to anyone, not as a preacher, but and not as out of shame, but to
Mm,
say this is just who I am. And I mean, quite frankly, that's what 12-step recovery for drug and alcohol has been for years. Quite frankly,
mm,
and it's just um, but that really is the way to break down the stigma is to get the person who has been directly involved, who's already gone across the line, I guess you would say, who's already gained the infection, who has gained you know gained the experience of what can be done. And when other people see them being able to be who they are given what's happened to them, um, it does make some differences. Uh, uh, but it is definitely grassroots, um, and uh, the other part about it, and the other reality, and you touched on it earlier, is that the politicians who were in control in the 80s and the 90s were uh, 90 to 10, they were white. And so if you had white people approaching them out of a white community, then they ended up, you know, uh, they would bring to bear legislation which brought money to certain kinds of things. And it's going to make it harder. I'm not going to say that this is not going to be harder. It's going to make it harder for for the black and brown communities because they do not have the same leverage at that level. But I think what you do have is the opportunity for some grassroots work is actually more productive.
It's interesting that you mentioned that, Quinn, especially surrounding the stigma and how having somebody with the experience that can speak on it genuinely helps break that. Because I remember exactly where I was when Magic Johnson came on TV and reported to having HIV, and he was ending his NBA career. Magic Johnson was my favorite player at the time. I loved the Lakers, and I was heartbroken when I found out about that. And I didn't know much about AIDS or HIV at the time, and it was because of him that I learned more about it. But I also, watched his documentary recently. They Call Me Magic, and he talked about that whole period. And I remember he was part of the AIDS Commission, the U.S. government's AIDS Commission under George Bush. And he worked with the commission reluctantly because he thought they were going to do some positive things for the community. He could bring some attention to it and whatnot. But he ended up leaving the commission because he found out they weren't really focusing on Black and brown communities, and they weren't doing the work. They had no really, even desire to go into those communities, those vulnerable communities, and do the work necessary to keep them safe. So he started his own foundation because he wanted to make sure that he could put his face and his name as an AIDS advocate, an AIDS awareness advocate, to helping people who weren't getting the help they needed, at the time. And I wish we had someone of his caliber during COVID who could have spoken to COVID with the same breath and same legitimacy that he did for HIV and AIDS back then.
I kind of, can I kind of feel like, I mean, I understand, what everybody's saying, but I think we're ignoring the fact that we're talking about a demographic that is very complex. That comes with, I mean, there's just vast variability across mindset. Um, Even within the culture, there are subcultures. There's, and I kind of feel like we've had people of his stature, of Magic Johnson's stature, during COVID who were infected. We've had people beyond his station and standing with that belonged to our community that got infected, that spoke up. The reality is, on some level, if it's not popular, we're not doing it. If it's not hip to get vaccinated, or if it's not a part of mainstream culture, we quite simply we don't want anything to do with it. The other problem is this is a community that dictates culture. We all culture is going to be on it. Well, the predominance of culture, the predominance of what's culturally acceptable behavior typically comes out of these minority groups. And if you're going to really trace back accurately, that's just what it is. I mean, even what we see in other ethnic groups, in true fashion, they're being emulated, right? And so what you have is a community essentially having to go up against itself, right? You have this mindset that, okay, basically what we're talking about is socially responsible behavior, because that's really all it boils down to, right? You being a responsible individual in this community in that makes up society. So being socially responsible, but being socially responsible around something that is so heavily stigmatized that impacts the same community more severely that you find yourself to be part of. And then you have to, I guess, sort of juxtapose that against, I guess, the preacher effect, the politician effect, and everything that they come with that also defines and designs, the mainstream of this subculture. Does it make sense? So it's sort of like a community going up against itself to correct itself, but what you're going up against is something so it's like the strongest part of yourself. I kind of feel like I know everybody says the conversation needs to be had, but at some level, I think we really need to assess what conversations we're having and insist on having, and are we even being honest about those? And then we need, at some point, conversation needs to stop. We just need action. I'm from a place where there are no questions about vaccines. There's no questions. You want it. There's no question. We don't care if you don't want it. If you want to go to work, if you want to go to school, you want to go to church, you go get the job. This pandemic, we always say when the U.S. sneezes, the Bahamas catches a cold, and so goes the rest of our region and into South America. We have adopted the same mentality that we see here, and it's the same. The culture starts here, and the mindset, is what comes next, and it propagates. And so now we have Bahamians, Jamaicans, Trinity, who are now saying, "I don't want, and you're not vaccinating me." And this wasn't our mindset. This wasn't we carried around passports, vaccination cards. But I don't know. I mean, I think it goes beyond just having somebody who has experienced it and speak to it. I think that person. I think we keep missing out education and outreach. People have to know what it is we're dealing with. They have to know what it is we're seeing. I think operating covertly is hasn't done any favors for anybody. I think we just need to let people know, hey, there's something out there that can kill you. Many of you are going to get infected, and many of you are going to infect others, and lots of you are going to die. And I'm sorry. I mean, but at this point, what else do we do? I mean, we're having conversations about letting grandma die so we can have a better economy.
Yeah.
You're leveraging human life with economy, and that's basically all this boils down to. And I'm sorry, Magic Johnson, you have access to stuff I know people that they will never have access to.
Yeah, that's a sad truth. This question, my next question, I'm going to ask three of you guys to answer different portions of it. But we know, just like with the COVID vaccines, it looks like there's some promising mRNA vaccines in development that could be a game changer for preventing the spread of AIDS and HIV. I'm going to ask Aaron, can you tell us a little bit more about these vaccines in development? And then Angie, I'd love to know what your thoughts are on you, whether or not you anticipate any issues with uptake like we've had with the COVID vaccines and vaccine hesitancy in that respect. And then Nisi, one of the biggest concerns people had during the evolution of the COVID vaccines was, how do we have a vaccine for this new virus that's come out, but we don't even have vaccines for HIV, and that's been out for years. So can you tell us the difference scientifically for why COVID vaccines were a little easier to develop than the AIDS and HIV vaccines? We'll start with you, Aaron. Tell us a little bit about these new vaccines.
So I haven't, and I don't want to say I'm disillusioned, but so all right, let's start. So the mRNA vaccines, they're basically just synthetic genetic material. mRNA, as Chili's explained earlier, that are transfected into individual cells, and you get that I guess production of that foreign protein, and that individual is incapable of expressing themselves, right? I admittedly have unplugged from not all things antiretroviral, but at this point, I think our community is requiring tangibles. We've been hearing about vaccines being in pipeline. We've been hearing about cures and races to cure and strides to the cure for years. And I don't know, I think it gets sort of burdensome, you get your hopes up, and then it goes away. Something as simple as somebody being elected to the wrong office, slashing funding across, you get burnt out. I do think that an HIV vaccine, it can only strengthen our arsenal. Do I think it would fix things ultimately, or I think it'll give us a few more rounds in the fight. Ultimately, I think that fight will change, and I guess I'm one of the guests would speak that. But I do think, just like we've seen with PrEP, we could be. I don't know, and my biggest concern would be if we did get a vaccine, what does that do for the race towards the cure? Are we setting ourselves up for a place, to reside in this place of complacency, relative to, what we all thought would have been, the overarching goal here? Um, and we get a vaccine, and then do we forget about, those members of our community who are HIV positive? Um, so I think it's a double-edged sword, to be honest, and that's just based on what we've seen. I mean, and even in recent times with COVID. I mean, we got vaccines, and we have people lying about vaccination statuses. We have security guards asking you for your vaccination card, and they don't know what they're looking at. And so, I am 100% certain that COVID positive individuals have been flying on airplanes. Um, so I mean, I don't know. I don't think. I think there'll be a good thing, but I think not without the necessary safeguards, and an adjustment in attitude. I think, and ultimately, I don't know that it will fix because I think the biggest problem is the sticker. I mean, believe it or not, I think it all starts with the mindset. If you can't fix that, then you just have another band-aid for another cut, another disease, another wound.
So, Andrew, what do you think about vaccine hesitancy if, when we do get these HIV vaccines, developed?
So I think there's two parts to that. One is HIV is a retrovirus, so it is totally different from COVID, where it duplicates and duplicates and duplicates and duplicates. So the methods that the reason why there's so much prolongment in getting the vaccine is that you can cure strand A, but B, C, D, have already mutated. That's piece one. Piece two, I think we will have a false sense of security and a non-compliance. So if it's like COVID and there's a wait, like Aaron mentioned, if there's a wait time and we got to go back, that we're not very compliant.
Mm-hmm.
The reason why you see such high deaths of people of color from HIV infections are from diseases that are being contracted because of HIV, is because we're not complying with our treatment. So we have the tools now where we could slow down our epidemic, but I think we'll have a false sense of security. So you will see an uptick as soon as a vaccine is presented, because I took the vaccine, I'm safe, and now I can go back to my risk behaviors. Same thing that happened with COVID. We got people who had shot one, and they immediately went back outside, unmasked. People have stopped washing their hands. I think we have gotten to the point where we have that we don't give all the information for treatment and the importance of follow through. Then we will have a huge uptick, because that false sense of security that I am cured, and I am not at risk anymore, means that we're putting more risk into the community, because you're not completely vaccinated, or your risk behaviors have increased.
Mm-hmm. To that point, I guess what we'll stay with you, Anji. What are some of kind of pivoting to PrEP? First of all, maybe we should start with, can you tell us about PrEP and what it is?
So PrEP is pre-exposure prophylactics. It's the same medication that we treat HIV with, that we can give to someone who is not positive, to help ensure that they stay negative. And then we also have PEP, which is post-exposure prophylaxis, that we use in case someone has had a risk incident, either a needle prick or sexual assault, something that they were not preparing for, and within 72 hours they can get treatment. And knowing those two, it's an ongoing process. People understand that taking a pill daily can reduce your risk. They're kind of used to that with like birth control. If you look at PrEP and PEP in the layman's terms, PrEP would be your birth control and PEP would be your day after pill. And so we're used to that terminology, so we could get on board with that. So instead of taking, for women, instead of taking one birth control pill, you would take two. And that is how we're going to protect you from both an unwanted pregnancy uh, as well as HIV. And then we have to make sure that we just continue to educate and push the compliance piece, because once you stop taking these medications, your risks are still there. And so if we're not addressing the behaviors of how to reduce risk, then we will have again another uptick if we're not compliant.
And I guess, Quinn, just as a follow-up, I know you had some comments earlier about the kind of the way that people are like sort of over relying on PrEP, and then that's leading to like this increase in STD incidents. And I just wanted you to kind of expound on that for a second.
Okay, well, PrEP does beautifully for the prevention of HIV. So there is no doubt about that. Uh, and if someone stays consistent with it, and part of the problem we've had during the COVID crisis is that people did not have as good an access to their sources of PrEP, and many different things. So first of all, I would just want to keep emphasizing that's good. I do not want to say that this is bad. What I just want to say is that it is only going to really be dealing with HIV. I mean, it has one of the components actually does do a little bit for HBV, which is hepatitis B, but that's not an issue anyway because we already have a good vaccine for that. So if people are on it, so. But the thing is that the other sexually transmitted diseases, the bacterial ones in particular, that we're really familiar with, those are not to be sniffed at. And Neisseria gonorrhea now is very difficult to actually cure. I mean, we've gone to the point to where it used to be quite easy with penicillins. I mean, now it's becoming so drug resistant. There's some question about whether or not we're going to come up with something that's just completely non-negotiable. It's just that's going to be a difficulty. Syphilis is no longer as easy to treat. In fact, the standard treatment for syphilis changed. It used to be just simply one whopping dose of penicillin and both sides of the glutes, and that was it. Now it's 3 weeks of treatment, going in and going in and going in. And these are difficult diseases. I mentioned the other one, chlamydia. That's another particular one, and hepatitis C, obviously. So, and those are controlled by barriers. We don't have um, uh, uh, the ability to have PrEP medications that I know of, at least, and I can't remember anything in my training. We don't have PrEP medications for those bacterial sexually transmitted diseases. The other problem is there's a synergy that happens to work with those as well with HIV, that if someone does get a lesion from the bacterial sexually transmitted diseases, it can make it more easy for them then to acquire the virus when they are exposed to it in the course of intercourse along the way. So that's really the relationship, and that's why it's not an exact parallel between COVID and barrier protection, but there is the whole notion of general sexual disease health along the way. Back for the differences in the vaccines. The strategy of HIV was to undermine the immune system. But you have to remember that was its first strategy, and therefore it is more difficult to figure out how to make the immune system be competent in regard to it, whether in advance or after the fact. Now, COVID's strategy was to tag onto one of the most commonly distributed receptors that really has nothing to do with the immune system in the whole body, the ACE2 receptor. And so their strategies were different, and therefore you could go at them a little bit differently. And that's one of the reasons why it's always been difficult, because HIV was it intended to it developed to be a duck and cover virus. You know, I will I will go in and I will do this, and then you won't be able to see me well,
Mm-hmm.
basically. And so that's just the reason it's taking a lot longer. The other thing too is that what people don't recognize is that work on coronavirus vaccines started um, back in 2004 with SARS, and if it had not been for the groundwork that had been done, for more than a decade, plus if it had not been for the advance of this wonderful Hungarian scientist who got thrown out of several different universities because of her research on mRNA, uh, but if it had not been for her work, we would not have been where we are now. Also, if we had not been for people like Dr. Peter Hotez, who says, look, we've also got another technology which is going to be really good to use as well, and we can do it. So there was some advanced stuff that had already been happening with either viruses within the same family or uh, technologies that were easily carried across to a new virus. And HIV has never been quite so amenable. But I'm very hopeful about the mRNA one. So
I am.
I am.
Quinn, historically we've had issues in general with folks feeling comfortable enough to get tested for HIV. Has the COVID pandemic uh, done anything to make that even more of an issue than previous, or have there been any obstacles created because of the COVID pandemic as far as people getting tested for HIV and their behaviors,
Yeah,
particularly in,
from
in
what?
communities of color?
Yeah. The biggest obstacle has been the fact that everyone's ability to get anywhere and to get into any offices and to do anything has been hampered by the COVID pandemic. Uh, Either because interests were so strongly directed towards COVID itself, and therefore funding was cut from other offices, or just because of the fact that you were stuck at home, or just because of the fact that public transportation was not working as well, because we, I mean, uh, our infrastructure has suffered terribly, and where people suffer most when infrastructure suffers are the people at the bottom, not the people at the top. The people at the top go and spend more money, and they spend their way out of an infrastructure disaster.
Yeah.
The people at the bottom don't. Uh, so that's just basically what I've observed. It's not so much a notion of a psychological effect of, oh, I shouldn't go get tested, or I'm afraid that now there's more of a stigma or something like that. It's just the fact that it's harder to go do it.
Hmm.
It was just harder to get to uh, the the public health offices that were open and doing free testing for HIV. Um,
Mm-hmm.
it was just harder to get there. Harder to get there when it was open and get the results back.
Yeah. Um, Aaron, I wanted to come back to you because I think when we kind of touched on this earlier, you had dropped off, but I think it's time to bring Miss Tina back into the chat. And I want to, I want to get Quinn and Angie's take too, but I want you to weigh in on this and the role that substance abuse plays in increasing risk behavior, particularly in queer communities.
Yeah. So Miss Tina, she's a bad girl. Um,
Why don't you tell the audience who Tina is? Let's start
so
there.
Tina is colloquial name. She is her government name is a methamphetamine. Um, and Tina is a very selfish drug. It's and it's a very prevalent drug now. I think it was something that was um, used militarily, and way back when, I guess when it was first developed, and then sort of used, I guess, or seeing the surface in more civil circles. Um, Specifically, the gay community at some point had become, I guess, synonymous with the drug, or its use, and so this sort of dates back to when circuit parties were still all the rage, and rage
Can you tell the audience what a circuit party is? Let's start. Let's go back. Come on.
and circuit parties. These are I mean, I'm sure everybody's been to an all-nighter once or twice, but these are all weekenders, extended weekenders. So these can go from Thursday to no, they can go on for days. And it's basically lots of drugs, lots of music, and everything that comes along with that when you bring certain components like music and dancing and scantily clad individuals together, right? Um, Everything that you think would ensue does and more, right? And so you do have this inhibition has left the room, right? Okay, it wasn't even invited, right? And so essentially, you have increased sexual activity. You have, if I put it this way, we're talking about HIV medication. If you're on a regimen, adherence also leaves the room. All right, so you've now compromised your adherence to this regimen. Um, you're now doing things you ordinarily wouldn't do, um, and these behaviors are typically very risky. I mean, they expose you to, so, and if you are negative, you're now exposed. Odds are you are exposed to the virus and a bunch of the virus's friends. Okay, so you're exposed to every STI out there. It's like jumping into a pool of sexually transmitted diseases.
Mm.
And well, willingly, really, because you engage in the drug use, and you basically, I don't know, you would have to put yourself in that environment. Um, and I think there's enough to know about those environments, before going in. Um, I don't know if that part made sense, but I guess what I'm thinking is during the pandemic, what we did see was more of these parties, um, more of we saw more of these parties, and one thing that I don't know, Quinn maybe can maybe speak to this a little bit. Um, I think back in the day, it was more about uh, you know it was dancing and sex was a part of it, but I don't think with sex like you know the the main objective. I think it was more of community and even defiance of what the government said about sex within the gay community. Versus now, these parties are even the drug is present to enhance the sex. I mean, the party is all about sex. And I was working with a company and stationed in Palm Springs during the pandemic, and I mean, there were parties at any given hour of the day. There were, I mean, people from all over the country, sometimes from around the world, just traveling to Palm Springs just to have sex. And Tina booked their ticket because she was always present. She was the host who did the most. I mean, she was always present, always present. Um, and that you know that this is the weird thing. The weird thing is now it is no longer a gay or LGBTQ community drug. It has infiltrated other circles as well, and we see women of all ethnicities. We see and of all stations. We see just people who you would never expect to be a party boy or a party girl, and of every age. Partaking in the behaviors that come along with, with Tina. Um, it's it's it, it, it's very, very prevalent, and to be honest, you it's so prevalent you can take a room of people, and it's almost guaranteed now that a certain portion of this room, and a substantial portion of this room, have had experience or are currently experiencing um, Tina and her,
Yeah.
everything that comes with her.
Mm-hmm.
And I don't know. I think I know there's always debates about gateway drugs and and what is and what isn't. One thing that I am certain of is that if you have never weren't sure before, well, you and Tina, you definitely have a gateway drug.
Yeah.
That one gives way to many others and has taken a lot from many more people.
Yeah.
So before we close, we want to get some final thoughts from you all on the topic. Any puzzle pieces that we haven't touched on? Any other thoughts you want to leave with our audience? I'll start with you, Miss Angie.
I think we've hit on everything, but if we put it together, the pandemic increased our opportunities to get together unauthorized, and so if I have young adults as children, so as children, I know that thinking about shared needles, clean needles, making sure the works were clean, condom usage in these parties that we knew were going on around the country wasn't done. And so you will definitely see an uptick because there's been exposure. And so now, and they don't have one sexual partner or one person that they're sharing needles with. It is a party, and it is set up and designed for multiple use. And knowing that our goal has to be right now, as Quinn said, is to push and push and push at the grassroots levels for testing, and we are testing any and everyone. So even if you're at risk, if you're an older person and you don't think you are at risk today, and your risk was 20 years ago and you've never been tested, the goal right now should be to test everyone so that we know the status and what we're working for. He is definitely correct. Our medication works, our prevention treatment works, but we have to get people into the doctors, into the clinics to get the testing and the treatment.
Aaron, you want to go next?
Sure. I think I would just like to close with, well, you know, um, specifically speaking to Black and Brown, and there's just people of color. Uh, Go and get tested. Learn about this virus, and just I know we definitely have, you know, we have more than one reason or rationale for not wanting to go to doctors or trusting healthcare, just given history. But I would say this: we can't secure a viable future if we're not here to enjoy it. Right? It doesn't make sense. It becomes an effort in futility. Um, I think we need to start caring more about our health, caring as much about our health as we do other social trends or cultural norms. We need to make healthcare a thing. We need to make healthcare a norm. I think this virus has ravaged communities for decades, but in 2022, going into 2023, we shouldn't be worse off than we were, entering like in the early 90s. Now HIV has a new face, and it looks like our mothers and our sisters, our daughters. I think we need to start having real conversations and truth and honesty, and stand 10 toes down and start protecting ourselves, protecting each other.
Amen to that. Quinn, you want to close this out?
Yeah, I would say that the, 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 the challenge for the brown and black community, and this is from an outsider's perspective, but it's somewhat informed by having or being a minority within a white community as far as being gay, but still, it's not quite the same. I'm never going to claim that it's the same. But the challenge is going to be to recognize, for instance, with HIV, uh, and that is to learn to enjoy sex, or if you're a person who chooses to use drugs, to enjoy drugs, if I can use that phrase, without losing yourself in either the sex or the drugs. That is and that can only be done if the person already has a foundation of a sense of self and community. And that is not going to come to these communities from my community. They're not going to be handing it out saying, "Oh, by the way, you guys are worthy."
Mm.
I wish that it could. You don't know how much I wish that it could. But the reality, it's going to have to come out of your grassroots of love.
Mm.
And that sounds so pablum-ish, but it is really the fact that it cannot happen otherwise. And the science still has to be there. The public work still has to be there. The infrastructure, yes, has to be there, but it cannot compensate for something which can only be the creation of these wonderful creative people.
Mm. Amen to that.
I love that you said that, because it's like, I think we start to internalize a lack of value in our own lives, particularly amongst, the Black Lives Matter movements, particularly amongst what we're seeing now with how life is devalued with the pandemic and white supremacy and white terrorism. It's hard not to internalize that,
Yes.
but the only way forward is to be radically inclusive. We can't continue to out-bigot the bigots and be prejudiced against people within our own community. Like, we shouldn't be out Naziing the Nazis,
That's
Angie, can you say what you just dropped in the chat, Angie?
I said to Quinn's comments about the grassroots, I said there has to be a community of compassion to help move the work.
Yes.
That part.
Yes. And I want to be there with you, and I wish that we could be there as the source, but we can't be. I told someone the other day who was dying, I said I can cheer you up and I can cheer you on, but I can't fight your battle.
Mm. Mm.
Yeah. But I think to that statement, even though we're talking about Black and brown individuals, having allies in the work does help. I think we, it's just like Dr. Hudson just said, we can't hate we all coexist on this earth. We can't hate our way into health, because health comes from the collective science. The reason why COVID went so fast, that everybody worked together. That was the absolutely only way we got that vaccine so fast. We've allowed the vaccine for HIV to be left in the hands of scientists or individuals that we believe that are of a higher value. We can't have people of color not in test studies. We can't have them not participating in. The biggest thing for me is the high blood pressure medicine, lisinopril. The reason why it affects Blacks the way it does is because we weren't in the studies prior to the medication being prescribed. It does work. It does help reduce blood pressure, but it doesn't work for us. And the only way we can do that is be at the tables, pull up a chair if there's no more room, and be a part of it, and bring that compassion and grace with us.
For sure.
Yes.
So many jewels, so many jewels.
Yeah.
I have to thank all of you for the gems that you've dropped on us today and the knowledge you brought to our audience. Thank you so much for joining us today. Thank you to our listeners for tuning in to this episode and those who will watch it on demand. Uh, this was a great episode of Let's Get Vaccinated on Hood Med Chats, and we just appreciate your presence. At Hood Medicine, we bring you real talk and mad science so you can make the right decisions to keep your loved ones safe. Please follow us on Facebook, Instagram, and Twitter to support our effort, donate to our cause, or find out about our next events. Visit www.hoodmedicine.org to find us or find us on social media at hood_medicine on Instagram, Twitter, Linktree, and TikTok. Hood Medicine Initiative, all one word, on Facebook. You can also support us through Bonfire at our Gorilla Gear merch shop, bonfire.com, um, /store/gorilla-gear. And be sure to come through to listen to our expert scientists, physicians, hackers, and assorted geeks on Routine Checkup with Hood Medicine every Monday at 11 a.m. Eastern on the Marie Daniel Favors Show on SiriusXM Urban View Channel 126. Thank you again. Stay safe, get vaccinated, mask up. God bless you all. Take care.